Hello friends, today we are going to discuss about the management of life-threatening asthma. So first we will understand the classification of the asthma. The classification of the asthma is based on the uh, percentage of the response on the uh, peak expiratory flow rate. If there is a 75% to 50% response, then it is an acute moderate asthma. If it is 50% to 33% response, then it is classified as acute severe asthma. If the response is less than 33%, then it is classified as the life-threatening asthma. Now, why it is important to know the classification? Because on the basis of the classification, the treatment of the asthma varies. Now, management of the acute severe asthma. About oxygen therapy and target. Although the asthma is primarily the large airway disease, some patients with acute asthma exacerbation may present with the hypoxemia of varying severity, and the targeted oxygen therapy is recommended. The BTS guideline currently recommended the oxygen saturation of 94 to 98%. A randomized control trial of 106 patients presenting to the emergency department with acute severe asthma concluded that high, co- high concentration of oxygen therapy, that is 8 liter per minute via medium concentration Hudson face mask, significantly increases PaCO2 and recommended titrated regimen where oxygen is only administered to patients suffering from hypoxemia with the oxygen saturation of less than or equal to 92%. It is essential to avoid both hypoxemia and hyperoxemia and supplementing inspired oxygen to current recommended oxygen saturation target of 94 to 98% appears safe and appropriate. Now about nebulized bronchodilator. Nebulized beta-2 adrenoceptor agonists, that is salbutamol and albuterol, are central to the treatment of acute severe asthma exacerbation of all severity as well as for day-to-day maintenance. Beta-2 adrenoreceptors are the G protein coupled transmembrane receptor that exist predominantly in the airway smooth muscle cell. They activate the enzyme adenyl cyclase, which produces the cyclic adenosine monophosphate that likely activate the protein kinase A and the modification of intracellular calcium concentration. So difference in the activity of the beta-2 agonist mediate the kinetics of how airway smooth muscle respond. For example, salbutamol directly activate adrenoreceptor while salmeterol interact with the receptor specific auxiliary binding site. The first line therapy for the rapid bronchodilation requires the use of high dose nebulized beta 2 agonists driven by either oxygen or the air depending on the degree of hypoxia. Patient with the minimal response to the initial dose may require continuous or back to back nebulization. Intravenous beta 2 agonists are reserved for those patients in whom nebulized therapy cannot be used reliably or in those who require additional bronchodilation during extreme stages and are discussed in detail in later section. The adverse effect of beta 2 adrenal receptor agonists are well known and pharmacologically predicted. The primarily include tachycardia and tremor, but also have effect on the serum potassium and the glucose. These effects tend towards tolerance with the continued exposure, although this is of little relevance in acute exacerbation phase. About systemic corticosteroid. Corticosteroid reduces mortality, asthma relapses, and subsequent hospitalization and requirement for beta 2 agonist therapy. Since they take time to work, the earlier they are given in acute attack, the better the outcome. The BTS guideline advise giving steroid in adequate doses to all patients with acute asthma exacerbation. Regarding the route by which steroids are given, studies have shown that efficacy between oral, intravenous, and intramuscular routes is similar. Furthermore, there appears to be little difference in the efficacy between different formulation of corticosteroid. For example, prednisolone, dexamethasone, and methylprednisolone. A standard dose of 40 to 50 mg of prednisolone and 400 mg of hydrocortisone for minimum duration of 5 days is currently recommended. Although there are several acute side effects from systemic corticosteroid use in ICU, including hyperglycemia, hypernatremia, water retention, delirium, ICU-acquired weakness. The benefit of short-term modest doses of systemic corticosteroid outweigh this adverse event. Now about magnesium sulfate. Intravenous and the nebulized magnesium sulfate have long been proposed as the treatment for severe acute asthma. IV MgSO4 is commonly used in the initial stages of refractory severe asthma in the ED, but there is little literature on its use or effectiveness beyond this stage. The mechanism of action of MgSO4 is only partially understood, but is thought to compromise the following: inhibition of the cellular uptake of calcium via activation of sodium calcium pump, muscle relaxation via inhibition of myosin calcium interaction, and calcium dependent acetylcholine release at motor neuron terminal, and inhibition of prostacyclin and nitric oxide synthesis. Furthermore, there appears to be the degree of anti-inflammatory response via inhibition of mast cell degranulation, T cell stabilization, and attenuation of the individual's neutrophil respiratory burst rate provided by the inhibition of calcium uptake. The overall result of this effect is to increase bronchodilation and reduce the severity of acute asthma. Currently, magnesium sulfate is recommended for those who have refractory symptoms despite standard initial management. Now about intravenous aminophile. Methylxanthine can cause bronchial smooth muscle relaxation through multiple mechanisms and are one of the most commonly prescribed drugs for asthma worldwide. The effect of methylxanthine is due to combination of inhibition of phosphodiesterase enzyme, translocation of calcium, adenosine receptor blockage, and modulation of GABA receptor, resulting in accumulation of CMP and subsequent bronchodilation. However, intravenous aminophylline has a narrow therapeutic index and should be used with caution as it requires monitoring of the plasma concentration to avoid toxicity. Although intravenous aminophylline is sometimes used as salvage therapy, and clinical trials or large data registry are required to assess its effectiveness as an adjunctive treatment for patients with severe asthma in ICU. About intravenous salbutamol, it is unclear if IV beta-2 agonists offer additional bronchodilation beyond the use of regular nebulization that leads to better outcomes. Currently, there is no evidence to support the use of IV beta-2 agonists in patients with severe asthma in ICU. However, it is available as an additional bronchodilator treatment in those with severe airflow obstruction, and it continues to be used as rescue therapy in ICU patients. Now about acute life-threatening asthma, advanced management in the ICU. Patient with the acute life-threatening and near-fatal asthma should be admitted to the ICU for close monitoring and to initiate additional measures to optimize bronchodilation and ventilation. About high-flow nasal oxygenation. Asthma patients admitted to the ICU are often hypoxic, and supplemental oxygen therapy is one of the most common first-line treatment provided either via low-flow or nasal cannula or via face mask. Low-flow nasal cannula can deliver supplemental oxygen at a maximum rate of 4 to 6 liters per minute, while standard reservoir mask can deliver maximum rate of 15 liters per minute. Recently, several small studies have been performed evaluating the use of high flow nasal oxygenation for asthma exacerbation. Furthermore, high flow nasal cannula group have a shorter mean ICU and hospital length of stay and greater average comfort score. The meta-analysis of four randomized control trials totaling 175 patients showed that although high-flow nasal cannula appear to significantly lower dyspnea score, there was no significant influence on gas exchange, intubation rate, and hospital length of stay. Although the trial of high-flow nasal cannula could be considered for improvement of dyspnea in certain patients, it should not be regarded as an alternative to mechanical ventilation. Now about non-invasive ventilation. Non-invasive ventilation has physiological effect of reducing work of breathing and alveolar recruitment, improving dynamic lung compliance, offsetting intrinsic positive end expiratory pressure, improving gas exchange during acute respiratory failure. Intensive care admission and invasive mechanical ventilation for acute respiratory failure from asthma are associated with significant morbidity. While NIV is established practice for hypercarbic respiratory failure for COPD patient, the use of NIV during acute asthma exacerbation remain contentious issue. Patient with acute severe asthma often presents with hypoxemic respiratory failure rather than hypercapnic respiratory failure, and the primary aim is to optimize oxygenation while elevating airway symptoms with bronchodilator therapy. However, patients with later stage life-threatening or near fatal asthma may develop hypercapnic respiratory failure, often necessitated endotracheal intubation and mechanical ventilation. Despite the lack of robust clinical evidence and guidance on using NIV in asthma, more recent retrospective cohort studies document the increased frequency of NIV use. However, NIV failure can be associated with increased length of hospital stay and in-hospital mortality. Now about intubation, approximately 2% of all acute severe asthma patients will go on to require intubation and mechanical ventilation. Among ICU patients, nearly 36 to 46% may require invasive mechanical ventilation within 24 hours of admission. The decision to intubate is the clinical one, albeit considering other investigation and projected deterioration of patient's condition. Although variable depending on the combination of factors, the clinical indication for intubation in acute asthma are detailed below. So, relative indications are progressive exhaustion, increased use of accessory muscle, or change in rate and depth of respiration, change in posture or speech, failure to reverse acute respiratory acidosis despite intensive therapy, altered sensorium, severe hypoxemia with maximal oxygen delivery, and silent chest. Immediate indications are cardiac arrest, PaO2 of less than 8, PaCO2 of more than 6.5, severe obtundation or coma, impending respiratory failure with gasping and inability to speak, and respiratory arrest. Intubation in the context of this relative indication can be challenging. The intubation of such a patient requires rapid sequence intubation with close monitoring of cardiovascular status. Pre-oxygenation may not be straightforward due to air trapping. The larger endotracheal tube is preferred as it may help with subsequent bronchial toileting with the use of bronchoscopy. Induction agents commonly used are propofol and ketamine in combination with opioid and paralyzing agent. There are several potential complications that may arise during endotracheal intubation. Some are specific to asthma patients. These include worsening of bronchospasm and significant air trapping during and after intubation. Cardiovascular collapse from the depleted intravascular volume status and vasodilation from anesthetic medication and increased intrathoracic pressure leading to the reduced cardiac output need to be anticipated and managed effectively to prevent cardiac arrest. Now, potential complication during intubation is laryngospasm, worsening bronchospasm, and significant air trapping. Potential complication during intubation include aspiration, barotrauma, volutrauma, cardiovascular collapse, cardiac arrhythmia, and cardiac arrest. Now, mechanical ventilation. Although life-threatening asthma is rare, a small proportion of patients may require invasive mechanical ventilation. While invasive mechanical ventilation is not specific for asthma, it is offered as last resort while allowing time for bronchodilator therapy to take effect. Severe airflow limitation is the hallmark of acute asthma exacerbation. Patients with life-threatening asthma may present with severe respiratory distress, hypoxemia, arrhythmia, pulmonary embolism, or cardiac troubles due to airway air trapping with cardiovascular instability, and at later stages, hypercapnia and respiratory arrest. High airway pressure and dynamic hyperinflation can lead to air trapping, barotrauma, and development of pneumothorax and hemodynamic instability. The principle of mechanical ventilation in asthma is to avoid dynamic hyperinflation. The ventilation mode can be volume assist and control pressure cycle ventilation with tidal volume of 6 to 8 ml per kg of ideal body weight as a starting point. High inspiratory to expiratory ratio time is often required at 1:3 and 1:4 with lower respiratory rate that is 12 to 14 per minute. In the event of continued breathtaking, disconnecting the ventilator circuit followed by manual compression is required to improve dynamic hyperinflation. Now, the following figure is the pictorial representation of low volume figure during airflow obstruction and airway trapping, 9 out of 19 during acute asthma. So this is the flow volume loop dissipating. So figure A is normal, figure B is demonstrating obstructive pattern, and figure C is demonstrating airway trapping during severe acute asthma. So PEEP is generally applied to all mechanically ventilated patients to avoid alveolar collapse, and higher level of PEEP are often utilized for continued lung recruitment during mechanical ventilation in ARDS patients. In patients with asthma, airway obstruction and peak flow limitation result in generation of intrinsic peak, which can be measured by performing expiratory breath hold on ventilator. Excessive intrinsic peak can lead to gas trapping and consequently dynamic hypertension. Establishing optimal PEEP during mechanical ventilation for patients with asthma is contentious issue. In practice, most advocate an applied PEEP of 0 or reduced level of PEEP below intrinsic PEEP to minimize hyperinflation. Permissive hypercapnia is often adopted with deep sedation and neuromuscular paralysis at early stages to prevent patient ventilator dyssynchrony. Ideal ventilator setting following mechanical ventilation is will discuss, and review of mechanical ventilation strategy in asthma is described. So about anesthetic agent, ketamine is the dissociative anesthetic used extensively for its sedative and analgesic effect. It is a non-competitive N-methyl D-aspartate receptor antagonist, which is derivative of phencyclidine. Its molecule contain asymmetric carbon atom with two enantiomer, that is S-ketamine and R-ketamine, and racemic preparation commonly contain equal concentration of enantiomer. It has excellent bioavailability from both intravenous and intramuscular administration, with rapid onset of action and peak time to peak concentration of approximately 60 seconds. The duration of action of single bolus is 10 to 15 minutes, and its distribution half-life is 7 to 11 minutes, being cleared via hepatic route within 2 to 3 hours. The bronchodilator effect of ketamine was reported not long after its introduction to the market, with its use on children producing remarkable improvement in wheeze and respiratory distress. The use of ketamine in severe refractory asthma has continued since, particularly in the pediatric population. Ketamine's effect appear to be mediated not just via NMDA receptor antagonist, but via myriad of another receptor target, including dopaminergic, serotonergic, adrenergic, opioidergic, cholinergic, and ion channel, including voltage-gated sodium channel and hyperpolarization activated cyclic nucleotide gated channel. The effect of bronchodilation is thought to be mediated not only by direct antagonism of NMDA receptor-induced bronchoconstriction, but by increased synaptic catecholamine level via presynaptic reuptake inhibition, downregulation of intrinsic nitric oxide synthetase activity, airway smooth muscle relaxation via reduction of L-time calcium channel, induced calcium influx, and reduction of inflammation via reduction in macrophage recruitment. Ketamine appears to be used more frequently in pediatric population as an adjunct to the standard therapy in refractory asthma exacerbation. However, ketamine is commonly used as an induction and maintenance of sedation agent in patients with severe asthma. In summary, it appears that although there is potentially physiological argument for the use of ketamine as an adjunct to improve bronchoconstriction, inhalational anesthetic agent. Inhalational anesthetic agents such as isoflurane, sevoflurane, enflurane, and halothane are known to induce bronchodilation through blockage of voltage-gated calcium channel depletion of sarcoplasmic reticulum calcium store, and possibly through GABAergic mechanism. However, this effect is not seen with desflurane. There was early evidence in the 1980s and 1990s of clinical benefit in treating severe refractory asthma with halothane and isoflurane in both adults and children. However, these studies were small and involving only few patients. Isoflurane improves the arterial pH and reduces the partial pressure of arterial carbon dioxide in mechanically ventilated patients, and sevoflurane may provide clinical improvement in mechanically ventilated children with life-threatening asthma. It must be noted that the use of inhalational anesthetic agent in the ICU may only be performed in the presence of appropriate gas scavenging equipment along with specialized delivery device which are designed to conserve inhalational anesthetic. One such a device is Anaconda, which enables the administration of volatile anesthetics and is inserted between Y-piece and ET tube. While its use as an additional rescue therapy continues, further studies are needed to evaluate the clinical impact of such a device on robust clinical outcomes. Now, next is ACOR. Extracorporeal carbon dioxide removal provides a mean of fast and effective treatment of CO2 removal in acute hypercapnic respiratory failure. However, in comparison to the ECMO, the blood is not oxygenated before returning to the body. Given the solubility and the diffusion characteristic of carbon dioxide compared to oxygen, so ECOR requires much lower blood flow rate. Utilizing this system, the deleterious effect of invasive mechanical ventilation can be less. Several case reports have demonstrated that efficacy of ECOR in the adult asthma population. However, only limited comparative robust data exist on this topic. Significant improvement in the tidal volume, respiratory rate, and intrinsic peak and plateau pressure acidosis following 1 day of ECOR. So additionally, the use of vasopressors was significantly reduced after ECOR initiation, highlighting that correction of acidosis with subsequent reduction in ventilatory pressure can improve hemodynamic stability. Additionally, 76.9% of patients were able to extubate while ECOR was being delivered, further reducing incidence of lung injuries seen during asthma. So in this context, there was one trial which was a race trial, which was investigated the use of ECOR in acute hypoxemic respiratory failure. So in this trial, 412 patients were randomized to ECOR with reduced tidal volume ventilation and standard intensive therapy. So there was no difference in 90-day mortality. However, ECOR was associated with significant reduced ventilator-free day and much higher incidence of serious adverse complication, including IC bleed. The trial was subsequently terminated early. Therefore, despite this concerning initial result, the study may have been too underpowered to show any potential benefit. Now, the next is ECMO. Extracorporeal membrane oxygenation is an invasive supportive treatment used in critical care for severe respiratory pathologies refractory to standard intensive clinical practice, including pneumonia, ARDS, pulmonary embolism, and trauma. The various mechanisms by which ECMO can provide organ support depend upon its configuration. Blood is extracted from the central vein, passes through oxygenator, which extract the carbon dioxide while saturating the blood with the oxygen. The blood then passes back to the body via same and different central vein. VV ECMO provides respiratory support, essentially bypassing the lung. However, it necessitates the stable functioning the circulating system. An alternative configuration is to return the blood at higher pressures directly to the arterial circulation, thus bypassing both heart and lung, providing cardiovascular and respiratory support. The physiological benefits of ECMO during acute respiratory failure are to provide sufficient gas exchange while preventing ventilator-induced lung injury, reduce metabolic demand of breathing, and provide a mean of lung ultra protection with the use of low tidal volume and prevention of atelectasis and barotrauma. Furthermore, patients on ECMO can better tolerate more invasive airway clearance maneuvers such as bronchoscopy and bronchial wash, reducing the incidence of mucus plugging. The most frequent complications of ECMO are related to the cannulation and include bleeding, thrombosis, and infection. The rate of complication is determined by the Yeo et al. Was 65.1% with hemorrhage at 28.3%. This resulted in very few deaths. However, bleeding was an independent risk factor for in-hospital mortality. More conservative anticoagulation may reduce the incidence of this complication. However, trending the line between bleeding and clotting is difficult in critical care, and the use of ECMO can make this even more challenging. Clinician may evaluate clotting and bleeding risk both at initiation and throughout the ECMO delivery. Following CESAR trial in 2009 and recent COVID-19 pandemic, global utilization of ECMO has expanded greatly, and in UK, ECMO is the only delivered by dedicated specialist center. CESAR results in demonstrated relative risk of survival to 6 months without disability, while ECMO was used in adult with severe and potentially reversible respiratory failure compared to standard therapy alone. But after this, the Evolia trial was published, which showed the no benefit effect of the ECMO. Then about mucolytic. Since one of the primary pathological mechanism of severe asthma exacerbation and mortality is inflammation with subsequent increase in airway secretion and cast formation, it is thought that management of mucus plugging could lead to possible improvement in outcome. Range of mucolytic therapy has been trialed to combat this phenomenon with varying efficacy. Now about nebulized heparin. Heparin is an endogenous glycosamine glycan used primarily for its anticoagulant property. Inhaled heparin has previously been proposed as an adjunct to treat severe asthma due to speculation regarding its possible anti-inflammatory effect. Heparin has been shown to bind and inhibit variety of cytotoxic and inflammatory mediators, including inhibition of mast cell activation and mast cell mediators, along with inhibition of eosinophil cell migration and cationic protein. Inhalation of heparin is likely to suppress the initial reaction to allergen and exercise-induced asthma by preventing the release of mast cell mediator. Two case studies has been reported showing benefit of nebulized heparin administered early in the course of asthma exacerbation. However, little can be gleaned from this in terms of wider clinical effect. Now about recombinant human deoxyribonuclease. Airway obstruction by viscous mucus is one of the primary pathophysiological features of fatal asthma exacerbation. Recombinant human deoxyribonuclease has been used to treat several asthma respiratory conditions, most notably cystic fibrosis, for many years. The lysis of inflammatory cell leads to the free DNA that is thought to be primary contributor to viscosity and adhesiveness of mucus. So recombinant DNase is reported to liquefy this component by depolarizing extracellular DNA and thus reducing its size, leading to transformation of viscous mucus into flowing liquid. So rDNase is currently only licensed for use in cystic fibrosis as a solution of 2,500 units delivered up to twice per day via jet nebulizer. The BTS guideline on the management of asthma do not support its use due to lack of sufficient evidence. Much of the literature involving DNS is focused on treating patients with cystic fibrosis with only minority of studies looking at its use in asthma. However, case reports suggest the potential benefit in mechanically ventilated asthma patients, and further studies are needed to evaluate potential clinical benefit of both nebulized and bronchoscopic administration of recombinant DNase on clinical outcome. Now about helix. The primary component of atmospheric air are nitrogen and oxygen. The mixture of helium and the oxygen combinedly known as heliox, and it was used to reduce the airway resistance and thereby reduce the work of breathing. While having similar viscosity in nitrogen, helium has high thermal conductivity. Therefore, heliox gas mixture of 79% helium and 21% oxygen has a density almost 6 times lower than the atmospheric air. Further, CO2 diffusion and elimination appear to be increased since it diffuses 4 to 5 times faster through the mixture of helium and oxygen than through nitrous oxide and oxygen. Finally, helium mixture have been shown to mediate redistribution of the gas throughout the lung and produces an increase in alveolar ventilation through reduction in CO2 dead space and facilitated by better diffusion of CO2 in low density helium oxygen mixture. Thank you guys.